Hey my badass doctors! Today we have a 72-year-old man who presents to the clinic complaining of several weeks of worsening exertional dyspnea. Previously, he had been able to work in his garden and mow the lawn, but now he feels short of breath after walking 100 feet. He does not have chest pain when he walks, although in the past he has experienced episodes of retrosternal chest pressure with strenuous exertion. Once recently, he had felt lightheaded as if he were about to faint while climbing a flight of stairs, but the symptom passed after he sat down. He has been having some difficulty in sleeping at night and has to prop himself up with 2 pillows. Occasionally, he wakes up at night feeling quite short of breath, which is relieved within minutes by sitting upright and dangling his legs over his bed. His feet has become swollen, especially by the end of the day. He denies any significant medical history, takes no medications, and prides himself on the fact that he has not seen a doctor in years. He does not smoke or drink alcohol. On physical examination, he is afebrile with a heart rate of 86 beats per minute, blood pressure of 115/92, and respiratory rate of 16 breaths per minute. Examination of the head and neck reveals pink mucosa without pallor, normal thyroid gland, and distended neck veins. Bibasilar inspiratory crackles are heard on examination. On cardiac examination, his heart rhythm is regular with a normal S1 and a second heart sound that splits during expiration, an S4 at the apex, a non-displaced apical impulse, and a late peaking systolic murmur at the right upper sternal border that radiates to his carotids. The carotid upstrokes have diminished amplitude. Based on the case's presentation, what do you think is the most likely diagnosis? I hope we came up with the same working diagnosis, which is congestive heart failure, possibly due to aortic stenosis. If you got this answer right, you gotta be feeling like Okay, here are the breadcrumbs. He has symptoms of both left-sided and right-sided congestive heart failure by experiencing exertional dyspnea and episodes of angina-like chest pressure with strenuous exertion. He had presyncope, seeing that he's felt lightheaded and nearly fainted from climbing a flight of stairs. When someone has difficulty falling asleep, lying flat on their back unless they prop themselves up with pillows in bed or prefers to be sitting up, then they have orthopnea. Plus, he has paroxysmal nocturnal dyspnea as he described the occasional nights of waking up feeling out of breath, which is relieved from sitting upright. Inspiratory crackles heard on lung examination also suggest pulmonary edema, which is a sign of left-sided congestive heart failure. As pulmonary hypertension and edema can progress to right-sided congestive heart failure, we can also see signs of systemic volume overload from his pedal edema, given that his feet have become swollen, and elevated jugular venous pressure seen on his exam. The additional clues as to what would be the cause to him having congestive heart failure is seen with the late systolic murmur radiating to his carotid, the paradoxical splitting of a second heart sound, and the diminished carotid upstrokes, which all indicate that he has aortic stenosis. Congestive heart failure is the inability for the heart to effectively to meet the metabolic demands of the tissues, leading to systemic ischemia and hypoxia. So it doesn't mean that the heart has stopped working, because rather that the heart works less efficiently than normal. Heart failure can be chronic, meaning that it's been ongoing for months to years, or it can be acute, meaning hours to days, which can then proceed to cardiogenic shock. This clinical syndrome affects nearly 6 million Americans, being the leading cause of hospitalization in people older than age 65. Due to various possible causes, blood moves through the heart and the rest of the body at a slower rate, thus increasing pressure in the heart. As a result, the heart cannot pump enough oxygen and nutrients to meet the body's needs, and the chambers of the heart may compensate by stretching to hold more blood to pump throughout the body, or by stiffening and thickening, leading to weakened walls. As a result of a weakened heart, the kidneys may respond by causing the body to retain more fluid in the arms, legs, ankles, feet, lungs, and other organs, leading to the term congestive heart failure. Hypertension is the most common cause of congestive heart failure, whereas ischemic cardiomyopathy due to coronary atherosclerosis is the most common cause of CHF associated with impaired systolic function. Other common causes include diabetes, prior myocardial infarction, valvular disease, such as aortic stenosis from chronic pressure overload, or mitral regurgitation from chronic volume overload, chronic tachyarrhythmias like atrial fibrillation or bradyarrhythmias, hypertrophic cardiomyopathy, constrictive pericarditis, viral myocarditis, cor pulmonale, smoking, long-standing alcohol abuse, thyroid disorders like thyroid toxicosis, cocaine use, infiltrative diseases such as amyloidosis, hemochromatosis, and sarcoidosis, and taking medications for type 2 diabetes like rosiglitazone and pioglitazone, and NSAIDs like ibuprofen and naproxen, and some calcium channel blockers. Symptoms of forward failure, meaning low cardiac output or systolic dysfunction, include fatigue, lethargy, dry hacking coughs, wheezing, frequent lung infections, and even hypotension. Or on the flip side of the coin, symptoms of backward failure, meaning increased filling pressures or diastolic dysfunction, including dyspnea, which is the hallmark or most common symptom of left heart failure and may occur at rest, with exertion, while lying flat, which is basically your orthopnea, or while awakening from sleep, which is also known as paroxysmal nocturnal dyspnea. There's also peripheral edema, so we could see swelling of the lower legs, ankles, and feet, hepatomegaly, and ascites, where the patient may feel bloated, nauseated, or have abdominal pain with feelings of distension. Or we may see weight gain. Chest pain, or as we know, angina, would be another common symptom, especially if the underlying cause is coronary heart disease. Auscultatory findings may include an S4, which is an atrial gallop, or an S3, which is a ventricular gallop, low-pitched heart sounds that are best heard with the bell of the stethoscope. So congestive heart failure can vary. For example, some patients have isolated diastolic dysfunction with preserved left ventricular ejection fraction, meaning greater than 40 to 50%, which most often is a consequence of hypertension or simply from aging. 50% of CHF patients have impaired systolic dysfunction with a left ventricular ejection fraction of less than 40%. Some patients have isolated right-sided heart failure with elevated jugular venous pressure, hepatic congestion, peripheral edema, but no pulmonary edema. But patients more commonly have left ventricular failure with low cardiac output and pulmonary edema that progresses to biventricular failure. So, to put it in a nutshell, left heart failure causes fluid to back up into the lungs, leading to pulmonary hypertension and edema, which can then progress to right heart failure as it causes fluid to back up into the rest of the body, leading to portal and systemic hypertension and edema. Because congestive heart failure is often a progressive condition, the American Heart Association, American College of Cardiology, and the Heart Failure Society of America categorize the 4 stages of heart failure to determine the treatment plan, whereas the New York Heart Association ranks patients into the 4 classes of heart failure to determine the degree of symptoms and functional limits as well as prognosis. Unfortunately, once the patient is diagnosed into a certain stage or class, they cannot go backwards, only forward. Because identifying the underlying root cause of congestive heart failure is essential, diagnosing CHF is based on history, symptoms, physical findings, and echocardiography. I cannot stress enough that the main diagnostic test would be an echocardiogram, because we need to assess the ejection fraction and determine if there's valvular dysfunction. Another important thing to look for are natriuretic peptide biomarkers, such as BNP or NT-proBNP. Now, the difference between these 2 biomarkers is that BNP is biologically active and has a shorter half-life. I would suggest that NT-proBNP, although is not biologically active, it has a longer half-life, so it circulates in the body longer and is more sensitive at detecting earlier forms of heart failure. So cardiologists prefer NT-proBNP for managing patients for therapy monitoring. To rule out all other causes and conditions and determine the underlying cause, blood tests like CBC, CMP, BUN, serum creatinine, glucose, fasting lipid profile, LFTs, and TSH. We would also order an EKG, coronary angiography, UA, and chest X-ray to figure out the treatment plan. For example, After assessing the echo, the patient may need a valve replacement or an endomyocardial biopsy, or if the patient has multivessel atherosclerotic coronary disease with a low ejection fraction, then revascularization with coronary artery bypass grafting would be the way to go to improve cardiac function and prolong survival. Treatment depends on the severity and cause of the disease. In patients with heart failure, treatment mainly consists of lifestyle modifications such as smoking cessation, avoiding alcohol and any illegal drug use, physical exercise, dietary changes, as well as medications such as ACE inhibitors, ARBs, and some beta blockers. If patients cannot tolerate ACE inhibitors, then we would substitute that with hydralazine with nitrates. So looking at the guidelines from the American Heart Association, American College of Cardiology, and the Heart Failure Society of America, we can see that the medications for stage A include the use of an ACE inhibitor or an ARB with a beta blocker, if they also have hypertension or a previous MI. For those in stage B, all of the treatment methods for stage A applies, and now surgery options should be discussed. For stage C, all the treatment methods for stage A applies, but now we also have the use of diuretics and digoxin as well as an aldosterone inhibitor. Aldosterone antagonists such as spironolactone, which is a potassium-sparing diuretic, may be used in class 3 or class 4 heart failure with persistent symptoms according to the New York Heart Association classifications. We can see in stage C that we are asking our patients to restrict salt in their diet, monitor their weight, restrict fluids, discontinue any drugs that are worsening their heart failure condition, and an ICD is recommended. In stage D, all of the treatment methods from all of the prior stages apply, and now we're looking at serious treatments like hospital-based support, surgery options like a heart transplant, IV inotropic drugs, and even end-of-life care. In terms of botanical medicine, I would utilize Crataegus laevigata, or also known as Crataegus oxyacantha, which is also known as hawthorn. The parts that are used are leaves, flowers, and fruits. We would use hawthorn because it's an anti-atherosclerotic, positive inotropic, and negative chronotropic. The next one would be Convallaria majalis, which is lily of the valley, and we would use the leaves. It's milder and safer than using Digitalis purpurea, but it's not safe for pregnancy. Next is Digitalis purpurea, also known as foxglove, and we would use the leaves. It's a cardiac glycoside, positive inotropic, negative chronotropic, diuretic, vasoconstrictive, and it's also not safe for pregnancy. Next is Selenocerius grandiflorus, which is a night-blooming cereus or cactus, and we would use the stem and the flowers. It's a cardiac glycoside, and it's also not safe for pregnancy. In terms of diuretic plants, we would use Taraxacum officinale, which is the dandelion leaf. It's an aquaretic, and it's better than using furosemide or HCTZ because dandelion is a potent potassium source. Next is Aesculus hippocastanum, which is horse chestnut, and we would use the fruit because it's a venotonic for edema. In terms of nutraceuticals, CoQ10, L-carnitine, and taurine would improve ejection fraction by increasing energy and blood flow. Plus, CoQ10 gets depleted with taking beta blockers. Potassium should be supplemented for those on furosemide to prevent arrhythmias, lipoic acid to stimulate glutathione production, fish oil to help reduce the frequency of sudden cardiac death in patients who recently had an MI, D-ribose to help restore heart muscle tone, vitamin D to increase levels of anti-inflammatory cytokine interleukin 10 and to decrease pro-inflammatory cytokine TNF-alpha. Plus, vitamin D deficiency has been shown to diminish contractile function of heart muscle cells and distort heart muscle structure, triggering hypertrophy. Creatine to improve heart function and improve endurance and muscle metabolism in people with CHF. Well, this is all I have on CHF. I hope you've enjoyed this video. This is Dr. Sola signing off. See you next time. Mwah!
Oh, he's so handsome. What's his name? Yeah.